Perfect. So we're going to go ahead and get started. Thanks everyone for attending our Idea Lecture Series talk this month. We have Max Jordan Nguemeni Tiako, who is joining us as a medical student in his final year at Yale, let me fast forward here, at Yale University School of Medicine in New Haven, Connecticut. Prior to attending Yale, he earned a master's in bioengineering at the Georgia Institute of Technology in Atlanta, Georgia, and a bachelor's of science in civil engineering, civil and environmental engineering, where he graduated summa cum laude at Howard University in Washington, D.C. Max's life experiences have shaped his academic and extracurricular interests related to medicine. In terms of research, he is interested in improving the quality of care for people from marginalized and stigmatized groups. This interest has led him to develop a research thread in addiction medicine since his first year of medical school. Pulling from his background in civil and environmental engineering, he has also developed interests in how residential and occupational environmental exposures shape people's health, and in identifying key levers that can be activated as buffers against the effects of climate change and environmental racism. This has led him to research associations between access to nature and health outcomes, most notably hypertension in pregnancy, a leading cause of maternal mortality. As if this weren't enough, in his free time, Max hosts and produces a podcast titled Flip the Script, focused on elucidating mechanisms behind observed health inequities and highlighting the works of scholars, physicians, and community health workers who make it a priority to address said inequities. He also writes about racism in medical education based on personal experiences and observations. These observations have led him to developing a budding research interest in healthcare workforce diversity. This year, Max was recognized among Forbes magazine's 30 Under 30 in Healthcare for his work in health equity. In his remaining free time, he loves playing tennis, getting out on his bike, and notes that he has an appreciation for efficient public transit. We are so excited to welcome Max to the Inclusion, Diversity, Equity, and Advocacy Lecture Series to give his talk entitled Medical Schools as Racialized Organizations, the Role of the Resident Physician. And there couldn't be a more perfect day for Max to give his talk, as just today, his manuscript covering this important topic was accepted for publication in the Annals of Internal Medicine. Congratulations on this remarkable accomplishment, and I think I speak for everyone that we are excited to read your manuscript when it is published and can't wait for your talk today. Welcome, Max.
Thank you, Matt, for introducing me, and thank you everyone for having me here. It's an honor to speak at a Residence Noon conference as a med student. I'm going to just very quickly work on sharing my slides. Just give me a second here. Are you able to see? Okay. So as Matt mentioned, I'm going to discuss medical schools as racialized organizations. But before we delve far into this topic, I want to just begin by sharing a story which basically got me started on the subject. So during my third year of med school, I think I was about 3/4 of the way through my clerkships. I had for the first time, I had a Black male resident, and we had a great experience working together. But unfortunately, it was only a once a week clinic instead of your typical everyday interaction with residents. But by the end of the 6-week rotation, he left me a great evaluation, and it left me feeling like, I think before this moment, no resident had really sort of taken the time to give me as thoughtful an evaluation as he did. And I'm pretty sure some of it had to do with the fact that we're both Black, and a lot of the patients we saw were Black, and he saw in my performance and interactions with patients things that one would want to see in a medical student at that stage of training. And so, unfortunately, though, the attending I was working with, who was a white man, literally said nothing in my evaluation. And so, interestingly, the way our evaluations work at Yale, and you've probably discussed this when you're reviewing our applications for residency, so there's a section that's basically the narrative comments. That's what goes into our MSVE. And then there's a section that's supposed to be formative. So the sort of feedback about perhaps what a student didn't do well, and what the student can improve upon. So this attending did have feedback for me. For instance, I struggled with initially with presenting with the mental status exam. I think psychiatry, or I thought at the time that psychiatry had some idiosyncrasies that did not necessarily, click for me as someone who would end up going into internal medicine. And but there was, for instance, no mention of the final presentation I gave, or how I was able to connect with so many of the patients that they otherwise, would have warned me, oh, this patient doesn't speak much, don't take it personal. So it was a little disappointing. And I emailed my clerkship director because, everyone wants their evaluations to count. And unfortunately, my residence evaluation never made it into the final transcript. So in my email to the clerkship director, I said, hey, I noticed, Dr. So-and-so had nothing to say about my performance for the 6 weeks. But Lambert, my resident, had all these great things. How come Lambert's eval doesn't appear in my final transcript? And the response was, well, for this very specific rotation, we do not want evaluations from residents. We want evaluations from faculty, and those are the rules of our curriculum committee. But it doesn't matter anyways, because you did so well on your psychiatry rotation, and we're very proud of you. And indeed, right, I had done really well. Everyone left me glowing reviews, except for this one attending, I guess. But what remained, though, in my mind was, well, what if I had been a borderline student, which was the case later in some other, right? Like there are times where you're not always an excellent student. What if I was a borderline student and needed that push from Lambert's evaluation to get me from, say, a high pass to honors, right? Or from pass to high pass. Like, what if that was the case? And it left me thinking, first, among our, amongst the residents at Yale, I think 6% of the residents are Black, 3% of the faculty are Black, and I think something like 10% of medical students are Black. So diversity or racial representation sort of decreases as you go up that hierarchy. And so for me, I've never had a Black attending. I'm about to graduate medical school, and never have I worked with an attending who was Black who could write me an evaluation. But I've had 2 Black men as residents and 2 Black women as residents. So it left me thinking, if we prioritize attending's commentary over residents' commentary, but even though we spend more time with the residents as medical students, then we are almost unintentionally creating a kind of disadvantage along racial lines. And so that's how I fell down this, or sort of landed on this path of studying organizational sociology and psychology in my very limited free time as a medical student. So that's the story. So briefly, I would love for everyone who is here today to become familiar with this theory of racialized organizations and to apply it to your own analysis of medical education, as well as thinking about the implication of this sort of racialization of med-ed for workforce diversity efforts, as well as racial health disparities. I will discuss a little bit of historical context and make it clear why I think this matters. A few definitions, and then I will review the evidence, right, that supports my theory that medical schools are racialized organizations. And I will talk about the role that residents play in this context, and how residents can also serve as agents of change and support for medical students, and ultimately discuss career and health implications for medical students and some potential larger sources of change. So historical context. So, I always think about medical school and ask, whose medical schools are these, right? So this is a picture from the 1800s, when initially the role of Black men in medical school was to be the handler of bodies from which white men would glean knowledge from, in their anatomy classes. And of course, at the time, medical schools were also gender segregated, right? And so you fast forward to 1910, when there are Black medical schools, right? And the Flexner report comes out, which was supported by the the American Medical Association and the Carnegie Foundation, and leading to the closure of the majority of HBCU medical schools. And I'm going to read this quote from the Flexner report, okay? Out of this very long report, there were specifically two pages that focused on Black medical education. He goes, "The physical well-being of the Negro is not only of moment to the Negro himself. 10 million of them live in close contact with 60 million whites. Not only does the Negro himself suffer from hookworm and tuberculosis, he communicates them to his white neighbors. He has his rights and value as an individual, but the Negro has, besides the tremendous importance that belong to a potential source of infection and contagion. The Negro needs good rather than many schools, schools to which the more promising of the race can be sent to receive a substantial education in which hygiene rather than surgery is strongly accentuated." Hygiene rather than surgery, and I want everyone to keep that little bit in mind, because I will bring that up again later. So why do I think this matters? And so a lot of the time when people make an argument in favor of diversity, it's a very utilitarian argument, which I will also share. But I think first and foremost, it's a matter of just morality, right? It's fairness. In this society, physicians are sort of at the top of the ladder, at the top of hierarchy when you think about income. And so for many people, especially for people of color who are from lower socioeconomic status, medicine is a path to upward mobility. Of the people I've worked with in the hospital, the majority of the Black people are custodial employees, and the majority of physicians that I've worked with are white or East or South Asian. Now, the more common refrain of why diversity matters is that workforce diversity is key to addressing healthcare disparities. That's true. More diverse teams tend to then lead to creativity and innovation in terms of scientific inquiry. And that has been empirically shown, right? So in not just the team, but also at the individual level, people who are minoritized in a given field have been shown to then produce PhD dissertations that are more novel, more likely to solve social problems, and more innovative, right? And that applies also to men in nutrition. So there is something about basically being an individual in the minority in your field that shapes your outlook on how you may approach problem solving. So something else that matters, why this matters, is just the degree to which we've made little progress in academia, right? So Black people make 13% of the US population, 5% of all US physicians, and only 3.6% of academic physicians. And then when you look at the admission rates, right? So number of Black people accepted in medical school every year since 1996, it is almost obvious that there was kind of a ceiling around 1,200 between 1996 and 2015. The number sort of hovers around 1,200 every single year, no matter what the number of applicants was. And then it like creeps up a little bit in 2015, right, up until 2020, where it's now around 1,400. So, I'm not saying that somebody is pulling strings, behind the Council of Medical Schools, but it's really conspicuous, right, that every year the number is just about the same, regardless of what the number of applicants is. Also, just generally thinking about individual specialties in academic medicine, there has been a steady decrease in the representation in most clinical specialties of all minorities, not just Black people, right, between 1990 and 2016. And obstetrics and gynecology is the only specialty that has seen an increase in representation of any minority group, but very specifically an increase in representation of Black women. So then this framework, right, of the theory of racialized organization. So it has 4 tenets, the first of which says racialized organization enhance or diminish agency of individuals along racial lines. And sociologists like to define agency as a matter of one's ability to sort of actualize their future. And so if you think about, for instance, time, right, just in a given organization, minority faculty might tell you, I was hired to do research and be clinical, but I am then saddled with additional service work that is not recognized towards my promotion. That is a way that organizations function to ultimately decrease minority faculty's ability to actualize their future and get ahead and get promoted. There is a legitimate unequal distribution of resources, and whiteness is seen as a credential, right? And the reason, part of why we know that whiteness is a credential is that, for instance, any given organization that embraces the notion of affirmative action, right? It is done because we know that prior to entering an organization, having been white, all other things considered, is a form of advantage, right? And then when one enters an organization, being white itself is also a form of advantage. Of course, all other things considered, right? There are low-income white people who are faced a great deal of barriers, and they also face different struggles when they join an organization. But overall, right, all other things equal, whiteness is a credential. And the last tenet, which I always find really interesting, is decoupling, right? So basically, there's an informal application of formal rules that ends up landing along racial lines. And a really good example is the NFL, right? So last year, 2020, the whole country is kind of on fire. And the NFL is making now brand new statements around, Black Lives Mattering. But in real life, what is the NFL doing? The NFL is also blocking this, they're in the middle of being sued by Black football players because the NFL is refusing to reimburse them appropriately for their prior experiences with concussions and the use of race-based medicine, right, in assessing, in the assessment of brain function, right? So on paper, Black Lives Matter to the NFL, but in real life, they don't. So this is what decoupling means. I'm gonna skip this. And I always like using this as a little bit of a joke, right? But this is a yearbook photo from a couple of years ago, Savannah Tomlinson, who said, anything is possible when you sound Caucasian on the phone. And I highlight that to say that for any given individual, right, the sort of performance of race, class, gender, sexual orientation, those kinds of things, they're inextricably linked. And ultimately, we perform who we are, right, in these different layers of identity, and how people perceive us, varies greatly based on our performance, but it has limitations. So I am a tall, dark-skinned Black man, but you best believe when I call customer service, I put on my best white voice ever, right? But if the person saw me and saw what I look like, they would not treat me the same way they would just based on how I sign. So this is what I mean when I say this. So the point of this slide is to say, a lot of the data that I will present is based on averages, right? But then the ultimate effect, right, will vary based on how individual students perform, their race, their class, their gender, and how others perceive those things. So I think about medical schools as having three sort of core pillars, right? So the first one is school structure. So culture, climate, and the pre-clerkship experience, which is very much a relationship building phase. We spend a lot of time in the classroom with friends, sitting side by side, and learning about each other and with crazy schedules. And then come the clerkships where we're professionalized, right? It's very much an apprenticeship time of our lives where instead of building relationships with our classmates, we're rather following residents and attendings around and sort of being, and I don't mean this in a negative way, indoctrinated into the profession. Then I think about career advancement opportunities and mentorship, and the residency application process. So when you think about school culture and climate, right, there is ample evidence out there, right, that minority medical students experience discrimination and stereotyping from colleagues and faculty. And we definitely do also experience sort of a pressure to both be a cultural ambassador, right, because of underrepresentation, but also a pressure to assimilate. And I always like to use the example of me going camping the week before medical school and then leading the orientation camping trip the year that followed. As a Black man, I'll tell you, I may never go camping again after I graduate from Yale. I mean, just kidding. I learned to enjoy camping, but before med school, it's something that I would have never done, but I did it to assimilate so that hopefully my classmates would, see me as one of theirs and like include me in the social things they would do, but it didn't even work. I think generally there tends to be a colorblind approach to student support. And overall, there can be a frequently tense racial climate in medical school. In terms of interactions with peers, microaggressions are fairly common, and there's good evidence now that experiencing microaggressions is associated with negative mental health outcomes. There's really something specific about social isolation and exclusion, especially when you are in the minority. And I very much relate to this. Rachel Hardiman's dissertation looked at race, gender, and class and mental health outcomes among medical students. And she found that very specifically that Black medical students had increased odds of experiencing depression and anxiety, and especially so among Black men who are further underrepresented in medicine, right? And they also, and I am one of those, have worse coping mechanisms and worse social support. And then there's this concept of the conscripted curriculum, which basically, it illustrates this phenomenon where faculty oftentimes conscript the minority students in the room when discussing any matters of inequality or racial health disparities, but at the same time, instead of inviting, having actual professional and experts to do this, which contributes to a minority tax. But then on any other given subject, then we tend to basically be devalued in terms of our contributions, right? There's a concept, and a lot of my female colleagues call this heap eating, right? Where like a man may say something in like noon conference and a woman may say something in noon conference and it not be acknowledged. But then when a man says it, everyone else is like, yeah, absolutely, I agree with Matt or whatever. But this is a phenomenon that also happens. And I've experienced this where I say something where, we're solving like a clinical case. My classmates don't believe what my classmates may assume that I'm wrong or something along those lines. And they'll double check what I have to say way more often than they double check other people. And when it turns out that I am right, rarely is it ever acknowledged that that was kind of messed up to doubt me, and it leads to divestment from discourse. What might shape all of this? I think a lot of it is a matter of capital, right? Especially perceived capital. So we think about social capital as who you know, cultural capital as how you know, who you know, and what you know, and ultimately human capital, which then shapes things like income. So when I say social capital, I mean, is your dad a physician? Is your dad the chair of orthopedic surgery? Cultural capital is things like me having gone camping in the Adirondacks now. So like, this is like a point of conversation I may bring to the table when I like start residency with a bunch of people who might be from, say, upstate New York or other parts of New England. Now, the reason why this ultimately ends up shaping interaction is that there's good evidence that, especially in the U.S., there's something about race and status associations, right, where basically white people often assume Black people to be of lower status, regardless of whatever, based on their perception of the Black person's capital. And so these different forms of capital very much, lead to say, for instance, a classmate deciding that they're going to invite me to the brewery because they may assume that, oh, he's Black, he doesn't like beer, right? I mean, this is a very mundane example, but those kinds of things happen. And it's the same phenomenon that leads to people assuming, for instance, that the Black physician who walks into a room is not the physician, but rather is here to, say, pick up the patient's tray. Cassandra Peel in her dissertation describes sort of a dichotomy where you have mostly minority students who are made to feel out of place in medical school, and a doctor dynasty, which is disproportionately white medical students who are sort of bred and were groomed to join medicine, and those students have better familiarity with the hidden curriculum and whatnot, right? And all of this is because of socioeconomic differences, right? So if you look at the backgrounds of medical students in this country, more than 50% of medical students come from the top quintile of US household income. A third of Black medical students come from households that earn less than $50,000, compared to only about 10% of white medical students, right? And I'm using Black and white, but like these disparities include also other minority groups, right? 52%, so the majority of white students come from households that earn over $150,000 compared to about a quarter of Black medical students. And then if you look at pre-med school debt, the majority of Black medical students have both educational and commercial debt in the highest buckets in terms of amounts of debt, compared to about a third of white students. And I think the AAMC does us a little bit of a disadvantage when they only collect information around household earnings, because in addition to household earnings, there's a huge racial wealth gap, right? A Black family on average has 10 times the net worth of a white family. A Hispanic family has on average 10 times less the net, so 10 times less and 8 times less the net worth of a white family. And what that means is, so someone's parents, right, might earn, a Black student's parent might earn, I don't know, $250,000, but they may be the first person in their family to reach that socioeconomic strata, which means then in terms of social networks that they may be supporting other family members, right? And so the sort of benefits that one would, the benefits that household earnings alone might yield for a given student are different along racial lines. So when we get to the clerkships, right? So this is all that we've experienced, right? Microaggressions, all that kind of stuff from our classmates. And then the same thing happens on the wards, but coming from residents, faculty, nurses, patients, right? So there's a lot of being excluded from the from learning opportunities and social aspects of the workplace. And I think some of this takes place in people seeing themselves in you as a student or not, right? And so, for instance, I've been on rotations where, you know, the resident may show more interest in the other, in my other medical student, in my co-medical student on the team who's white, and they like, you know, talk about the vacations they've both been on, but like not at the same time, but like places they've both visited, right? That sort of cultural capital aspect of things, which then shapes whether, for instance, like you're going to call me or call my classmate for that delivery, like that literally, right? Like when you, and I think, and because we're here in OBGYN today, I think this is especially unique for surgical specialties, because so much of your learning, and you might relate to this as residents too, where so much of your learning depends on the person above you trusting you and liking you. And all of those things, right, are subject to all the biases that you can think about. So if someone doesn't like or trust you, they may not let you ever suture in their operating room. They might pimp the crap out of you, right? But so much of the learning in the workplace, and especially again in surgical specialties, is shaped by these dynamics. So then all of this leads to, you know, Black students experiencing the highest amount of stereotype threat. There's a recent study that showed 82% of Black students experience stereotype threat, and then 46% of Asian students, then 44% of Hispanic students, compared to only 4% of white students, right? If you look at grade distribution, there are stark disparities where basically every racial minority group is graded worse, all other things considered, on the clerkships compared to white students, but it's especially worse for Black and Native and Hispanic students, so the students who are URIM. There's this concept, and I literally experienced this was crazy, where basically this is called the amplification cascade. It's a phenomenon in which basically a small difference in the assessment in student performance from the clerkship director leads to a larger difference in grade and selection. So for instance, in this study at UCSF, they showed, so just 1/10 of a point on the clerkship director's assessment scale led to half as many honor grades across all clerkships for URM students. And it's funny, I was then in one of my rotation, a borderline student between a high pass and honors, where I was like, man, I just need the clerkship director to decide basically whether I would get honors or not, because it could go either way, because, right? And unfortunately, the clerkship director was like, oh, sorry, I think I'm gonna give you a high pass here. And I was kind of gutted because I know this evidence, right? Like I live in this literature, and I was like, you, right? Like we've had a good relationship throughout this clerkship, and so much of these evaluations anyways is kind of subjective, that, you know, what, again, whether someone likes you, whether someone spends time with you ends up shaping your outcome. Then when you look at, you know, the comments in evaluations, right, where basically Black medical students are more likely to be described with using, you know, terms like competent or hardworking. whereas like white medical students are more likely to be described using standout words like excellent, intelligent, the superlatives, right? And this is all other things considered, right? So even students that have the same grades, and you look at the MSPE, right? Residency program directors use these coded, these coded terms to decide whether or not they're going to rank a student one way or another, right? So two students with the same step 1 score and the same clerkship grades and all those kinds of things, they're described, qualitatively very differently on average, right? When you look at these studies. And so what is the role of residents, you might ask? So residents and attendings, right, are cited as the lead perpetrators of exclusion, bias, and abuse, including neglect, right? As you see the study here, residents are the sort of chiefs of perpetrating these experiences on the wards. And I think it is not that residents are particularly meaner, but we spend so much more of our time on the wards with residents, right? You see the attending like during rounds and then they disappear. But you're with the residents all day. They get to send you home or keep you around. People experience a great deal of public humiliation, which also contributes to sort of an obstruction of learning, exclusion from the medical team, as I mentioned earlier. These are the most common forms. And as I mentioned earlier, surgery and OBGYN are consistent. There are several studies out there, right? They're consistently listed as the top 2 specialties where students report the most abuse writ large, right? And the AAMC questionnaire, where a lot of this data comes from, doesn't necessarily tend to tease this out in terms of racial discrimination versus not. But there are other studies. So, for instance, 32% of Asian students, 38% of URM students, 33% of multiracial students report experiencing mistreatment, compared to only 24% of white students. And then if you look at specifically racial discrimination, 16% of Asian students, 23% of URMs, 11.8% of multiracial students report specifically racial discrimination, compared to about 4% of white students. So you might want to ask, well, what can residents do? I think residents can serve as an anchor, right, to students on a given rotation. When I come on to, I don't know, labor and delivery, I don't know this world, right? The residents, you all live in this space, and so it behooves the resident to really orient. I mean, and it's always said on paper, but unfortunately, so many interventions have been done, but there's been little change in how much in how much medical students report mistreatment or discrimination on the wards. I think residents can be intentional about treating students as part of the team and as colleagues. I think for me, when I was on the wards, even when I expressed interest in a given specialty, actually this happened to me on OB-GYN when I used to want to be an obstetrician, where I clearly wanted to be one, and the other medical student on the team with me who wasn't Black would be told, oh my God, you make such a great obstetrician. And she hated it. She hated OB. She's a psychiatry resident now. And I was like, oh yeah, I want to do this. I love this, da, da, da. And like, I just felt like I was unwelcome from like day one, that, residents didn't really have much interest in teaching me. And, I talk about perspective taking a lot, because residents were once medical students. I can't ever, and I'm sure y'all can't ever forget the experiences you had as medical students, right? But of course, there are other structural elements here where residents are burnt out, and it's really hard to like have a medical student next to you who like follows you to the bathroom. But just remember what it was like to be a med student. And something else that I think about is sometimes when the attending is the person who's perpetrating these experiences of discrimination, the residents can really serve as a bridge to build that gap, right? And I remember actually, I was in the operating room once where I'm left-handed, right? The attending was left-handed, the resident was left-handed. I was so excited. This was the first time I get to be in the OR, and like, I don't have to ask that my instrument be like, loaded the other way, because everyone's left-handed. But very quickly, that excitement went away, because the attending only spoke to the resident in the case. And, she would ask her, oh, where did you grow up? That, like, all that kind of stuff. And one thing that I wish this resident could have done in that moment would have been then turning to me, Max, what about you, right? That's just such a simple gesture of including the person on the team that otherwise often gets left behind, neglected, and whatnot, right? But that didn't happen, and it's fine. But these are things that residents can do to make it such that medical students feel like generally included as part of the team. So then when you think about career advancing opportunities and how those things shape outcomes, right? So AOA, which is like, you know, the golden ticket to probably any top program, I'm guessing. So Black students are six times less likely to be inducted in AOA compared to white students, and Asian students 2 times less likely to be inducted in AOA. And that very these two statistics really strike me in that it, you know, brings me back to the piece I mentioned earlier about the limitations of performance, right? Black people and Asian people are like the least likely to present as white, right? So as good as your grades might be, as good a performance one might put forth in terms of, like, you know, race and class, if you don't look white, then just look at the numbers. So then in terms of research and mentorship, right, as I've mentioned, I mean, there's generally lower faculty diversity, which then shapes whether faculty even, you know, express interest in mentoring students. There have been across many fields, not specific to medicine, audit studies, right, where you email a faculty with a Black sounding name, they're less likely to respond to you and say, yes, I want to mentor you. And you know, at schools where there's no AOA, like my medical school, if you look, so having an effective research mentor is the chief sort of contributor to someone being nominated, getting honors, and getting highest honors. And at the same time, URM students have the lowest odds, right, of receiving honors, half the odds of being nominated for honors, same with receiving honors, and then only 0.2 in terms of odds of getting highest honors. So like in a 13-year span, 2 people, right, in this study, right, 2 URM students got highest honors. And then we've basically accumulated all this disadvantage, right? And then it's time to apply to residency, right? And before we even get there, right, URM students are at increased odds of taking a leave of absence, also have greater odds of attrition. And of course, you know, graduation rates in medical school are high. Like, you know, almost everybody graduates from medical school, but when people don't, they're more likely to be minority. Lowest odds of matching at the 4-year mark. So for instance, if you look at, you know, people who have to go through the match more than once. So it takes the 6-year mark for everyone to have been in residency in this most recent study. And so then things like, you know, cutoffs, right, that end up disadvantaging Black applicants. I know there are programs out there who will say, oh, we have, you know, or specialties like derm, like if you don't have a 240, forget about going into dermatology. That's, you know, that's what they say. And so the cutoffs tend to disadvantage students almost unintentionally, or maybe intentionally, I don't know. And that leads to an overall higher cost of application, because if you are perceived to be a less competitive applicant, then you have to apply to more programs. Then there's this phenomenon where there is a matter of like opportunity hoarding, right? So the applicants that are, you know, bright stars, so like in internal medicine, 12% of applicants are offered 50% of interviews, and then they attend 25% of interview. So there's that tail of that curve, right? Students who receive a really tiny number of interviews, and that too is racialized, right? And so then you think about career trajectories and mental and physical health. For instance, I already mentioned the scores. If you look, there is a really, really tight correlation, right, between USMLE Step 1 scores and you know, the sort of average score in a given specialty and one's earning potential, right? The higher the score, the higher the earning potential. And in addition to that, as I mentioned earlier, right, exposure to mentors is one of the lead factors that end up shaping whether people are interested in a given specialty. So is this even a matter? Is it like, are the choices we make even choices given all the structural things that shape where we end up going, right? And I mentioned earlier the you know, the hygiene versus surgery thing that that Flexner wrote in that report. It is clear that we have a hierarchy, right, of medical specialties for minority versus non-minority students. If you look back here, right, The surgical specialties are up here, right? Orthopedic surgery, neurosurgery. Derm isn't quite surgical, but maybe. But again, right, hygiene versus surgery. If you look at today, right, the hygienist of or sanitarian of 1910 is today's like frontline, family doctor doing the prevention of the spread of disease, right? And those who are considered quote unquote, or who have the lowest, step one scores are also have the least earning potential. And if you look at this hierarchy here, right? So for black residents, like will be most racially diverse and it's family medicine, right? Like, and then you look down here, it's ENT, right on opto, right? The specialties that again have that really high earning potential. So are we unwittingly sorting minority medical students into the least lucrative specialties? And so people argue sometimes that the debt burden is what shapes interest, but it's actually been empirically challenged. Medical students who go into primary care actually have the most amount of debt, which means that people go into primary care in spite of debt, whereas students who go into, say, ophthalmology and dermatology have the least amount of debt. So again, right, are we almost unintentionally or intentionally sorting students who are marginalized into the sort of undervalued specialties? And then when you think about long-term career impact, right, the students who experience abuse in medical school and discrimination, they're less likely to express interest in academic careers. But even among those who remain, there are stark disparities, right? Black faculty are are half as likely to receive a K award, and this is actually mediated by a bunch of medical school factors that we just discussed, right? Half as likely to be promoted, half as at each stage, less satisfied, more likely to consider leaving academia. And then when I think about individual health, right, I already mentioned the increased risk of depression and anxiety among students. And something that's really interesting in those data is that the students who experience the most depression and anxiety among the Black students in this cohort are the ones for whom their racial identity is really central to who they are. So students like me who like I'm Black and I'm proud, but like those are the students who experience, who are more sensitive, right, sensitive to these experiences of discrimination, which mediate the negative mental health outcomes. And then you look among residents, this recent studies show, right, surgery residents who report discrimination are twice as likely to also report suicidal ideation. And we talk about physician suicide all the time. I think in that conversation, rarely do we talk about what discrimination does. And long-term earnings, right? So, and for anyone who's in the room, I want you to consider this. So there's a recent sociology study that showed that Black people receive shallower health returns from education compared to white people, and some of that has to do with the health impact of perceived discrimination in these higher socioeconomic strata, right? There's good evidence that Black folks at higher socioeconomic strata experience greater interpersonal discrimination, which then comes with stress. And also because of how we're sorted, right, into different like specialties after having acquired this education. And a lot of the health benefits from education really come down to money. It's not just that being educated then shapes health behaviors, but it's also that being educated means you have more money, right? But all hope is not lost, right? There are external sources of change that can sort of turn things around. And I really like to highlight the LCME, right? It was 2009, not 2012. The LCME created diversity standards, right? Which almost immediately led to a reversal in the trends of representation of Black women in medical school, right? From, if you literally, I mean, this curve is beautiful. But then there are also internal sources of change. So for instance, conscious efforts, like for instance, this idea series that y'all started, right? This is an internal source of change within your organization that is meant to, say, raise consciousness amongst the members of the organization. And there are other things like, social movements, like for instance, the white coats for Black Lives that were started a few years ago, or the MedPeds program like Tulane that have sort of entirely reshaped how they do residency recruitment. But I think, some of the policies like the LCME diversity standards, right, could always be specific, right? So with the change, we've seen an increase in representation of Black women, right? That the policy was not specific enough, because if you look, for instance, since like, I don't know, 1996, the gender gap among Black medical students has just sort of stagnated, where 1/3 of Black students in med school are men. And that gender gap doesn't really exist for any other group, right? It's a lot skinnier in other groups. So thinking about how external forces that ultimately shape racialization within organizations need to be specific, right? If there are actual goals that an organization might be trying to meet. Now, I think sustainability is not promised. This takes a lot of work, right? We know that, this concept of the white lash, right? When there is increased increased diversity within an organization due to a perceived threat to status, people tend to actually be more aggressive against the minorities, and we saw that, right? Like Obama was president, and like who did we get after? It was Donald Trump. But also this concept of the theory of racial ignorance, right, which basically shows that oftentimes, white Americans sort of almost unintentionally show a sort of literally racial ignorance, right, that comes across as innocence and contributes to reifying inequalities. So a good study showed that the majority of white Americans gravely overestimate racial progress from the 1960s, right? And so then when they are exposed to evidence that there actually hasn't been a lot of progress, the participants who read about disparities from the past and the present, or then instead of acknowledging that, oh my, the present hasn't, things aren't so great right now, there's instead more likely to think of the past as even more unequal, right? To sort of rationalize or tell themselves that there has been some kind of progress. So that delta is the delta is what really changes in people's minds. It's almost as if we're, as a society, incredibly committed to telling ourselves that there has been racial progress when there hasn't. And I think that is part of what shapes inertia in settings like academic medicine. But ultimately, I think the solutions are clear, right, to addressing racism in medicine and in other settings. It's a matter of redistributing resources. There's grave inequality in our society, and flattening power hierarchies, right? Organizations like medical schools should remain or become accountable to their surrounding communities if they're not. I think in the short term, medical schools should do a better job at investing in K-12 education, right? A lot of schools basically rely on student-run programs to meet some of their diversity requirements that set by the LCME. When you have schools like Morehouse School of Medicine that are deeply, deeply invested in K-12 education with a much smaller budget than schools like mine, right? And so all of this would lead to broadening and deepening the pipeline, right, of students who would eventually be eligible to enter medical school. I think we also, as medical schools, need to apply pressure on systems that perpetrate inequities, right? The good example I like to bring up is the US News ranking, which literally, right, relies on markers like MCAT scores, right, which we know are basically, there's great racial inequality ahead of like who gets to do well on the MCAT because of the unequal distribution of resources. So NYU made itself entirely, tuition free a couple of years ago, and literally they catapulted to #2 medical school, right? And medical schools love their ranking, right? But if we rely on these rankings, right, to say we're a good medical school, ultimately, then we're going to perpetrate inequity, because the US News ranking literally relies on metrics that are based on unequal aspects of our society. So do we as medical schools ask of the US News ranking to incorporate an equity metric, or do we just ask for abolishing the damn ranking itself? So just something to consider in terms of the external pressures that also perpetrate inequities. I just want to acknowledge my mentors and the many scholars whose work I have been leaning on to, to give this presentation. And thank you all so much for giving me this platform. And I'll take any questions. I'm sorry I went quite over time here.
Great. Well, thank you so much, Max Jordan. I really appreciate it. There were some comments that came up during your talk. I don't know if any questions are in the comments box, but the photograph from somebody highlighted that the photograph from the anatomy photo was a photo from UNC. So
oh, wow.
Deeply personal to us.
From my anatomy, from one of our historian of medicine who taught us. Thank you for highlighting that. I will note that in the next time I give this presentation.
Great. Any questions for anyone?
Crickets.
Max, congrats on your publication, and thank you so much for joining our series and giving this talk. It was a really great presentation. I'm curious what as a graduating medical student, what your advice would be for the younger students who are on this call and who often participate in our lectures about the way that they can address their perceived experiences of discrimination or mistreatment. Especially in terms of their grading, and what advice you would give to them about how to have those conversations and make sure that they're being graded equitably and fairly.
Yeah, that's a great question. Thank you so much, Celeste. So I have a two-pronged answer here. The first thing I'm going to say is that medical school is incredibly infantilizing, right? We're almost pacified into accepting the outcomes that we get, right? You get a bad outcome and you kind of just suck it up, and because you don't want to challenge the hierarchy, right? But I think we as medical students can realize that even on the wards, like you work with residents, yes, they're above you in the hierarchy, but we're adults, right? And so it's okay to challenge something that you feel isn't right. And I've done that so many times, and I don't necessarily mean appealing. But I have appealed grades when I felt like something wasn't fair. I was like, we're not going to do this. So, just literally calling out things that are unjust. I mean, it takes a lot of poise, right? And not being afraid of retaliation. And I've done this and then was deeply, like I worked with an intern who then gave me a terrible evaluation. And then I had to work with them again a year later, and I was terrified, but it turned out okay. So I think, so that's one piece. And the other piece is, I think generally setting expectations, right? Being clear about communication and expectations is always a good way to go about it. And it has limitations, right? Like like if you didn't go camping, if you don't have a cat, if you don't partake in all of the things that someone else does, and they're the person who works with you, it may be more difficult to connect. But at the very least, having good conversations at the beginning of rotation about, okay, what do you expect from me, how, and checking in, right? Checking in, I don't know, weekly or depending on what the length of the rotation is. And the last thing is, I think it actually is a good idea to bring it up at the, address the elephant in the room. Like for instance, I have had XYZ experiences before. I would like for this experience to be different. Like literally say, I'm here to learn, and I think residents, this is another thing I didn't mention earlier. Residents can also ask, like, oh, what if you are mistreated? If you feel you're being discriminated against, please tell me. Or how would you like for me to address it if, say, a patient says something racist to you? Or how would you like me to address it if, a nurse or whoever, right? And making it clear that, hey, if you feel like something isn't going right, come to me and mention it. But I think as students, we need to sort of like take hold of our own agency and call things out when they're not right. And this is like jokingly, but like be a Karen, like ask to talk to the manager when you're not satisfied, like quite literally. And I do this all the time and it works.
Thanks, Max.
Thank you. Is there another one? Thank you, Justin.
Hey, I'm gonna ask a question. Strong work with this presentation. I think it's just I think just the more that I stay in medicine, the more I realize the experiences that people have across the board in the country are like very similar, and it's not, a lot of them are not isolated experiences. I think the question is what tangible like solutions, and you mentioned this with like residents, like in real time doing things and making changes that I think can be helpful. But what tangible things do you think med students, institutions, curriculum developers can do to make things more equitable and just more like just stuff that just makes more sense? Like I feel like in the system that we have now, it's hard to learn, and learning should not be hard. So what things do you think we can do to make learning easier? And then, yeah, I'll stop there. So I'm gonna start rambling.
So there's a paper that's coming out soon in social problems, I think, which is, it was an intervention on medical students, right, across race. Basically, one is, I mean, these are individual level interventions that always will be trumped by structural problems, but in the short term they work. So having a growth mindset, right? Like, so taking experiences as a learning opportunity it is helpful, right? Just kind of thinking about our own mindset when we're starting an experience in itself is it's like partly effective in how we end up sort of perceiving what's happening around to help with your learning. And then the other thing is another part of this intervention was basically kind of like a self-affirmation intervention, right? Like almost one of those, like, you are worthy, you're beautiful, the stuff that people post on social media all the time. But like self-affirmation actually works, as it turns out. One of the outcomes from the study showed that self-affirmation led to like more stability in Black medical students, like confidence in their test taking skills, and like feeling confident about going into a top residency. And so like all those psychological processes then end up affecting even how you interact with people, and buffering, say, stereotype threat. So at the individual level, that's something easy. Like you could become, I don't know, more embracing of that sort of growth mindset and self-affirmation type stuff. And then I think we need to throw the MCAT away personally, right? There are a few medical schools out there that don't take the MCAT, and their students turn out fine. I've had residents, right, who went to Brown for med school, where something like 80% of students at Brown don't take the MCAT, and they do fine. So that's one very tangible thing that we could decide to do tomorrow if we wanted. And in fact, a few med schools just this year, because of COVID, were like, it's fine, don't send us an MCAT because of, it's a pandemic. And so we'll see, right, what that turns out for Stanford and University of Minnesota as examples, right, of schools who are like, we don't care if you don't send us the MCAT. So that, very tangible. And I think ultimately, right, it takes critical mass, right? So medical schools need to become more diverse, and with greater diversity in the setting, right, then people are less, say, less afraid of having conversations about race, less, less frozen about the stuff, right? And it makes for a more just sort of comfortable work environment.
Thank you. That was great.
Thank you.
Hi, Max. Can you hear me?
Yes.
Okay, I'm in a warehouse sewing, so I'm sorry, but I do have great talk, but I do have a question just about wellness. With you being an advocate, in medical school and now starting residency soon, how do you avoid burnout, the burnout that can come with the Black tax when you spend so much time advocating on disparities?
Yeah, that's a tough question. I mean, like burnout, I don't know. I mean, like for me, I only do things that I like to do, right? So, and I think that's how I am, for the most part, not burnt out yet, right? There are some aspects, there are things about the minority tax that aren't always things that you may want to do. So I don't, there are just certain things that they want minority students to do around diversity efforts that I'm like, I don't like doing this and I won't do it. And so that's one thing, doing the things that you actually enjoy, because then it feels like a labor of love and a little less like a burden. And of course, that has its limitation, right? You only have 24 hours in a day. So that's one thing I would say.
Thank you.
Great. Well, thanks so much again, Max Jordan. I really appreciate you coming and talking to our group. Such a wonderful talk, and we look forward to reading that manuscript when it comes out and seeing all your work in the future.
Thank you so much for having me. This was a delight. I'm glad many of you have appreciated the talk.
Awesome. And I put it down in the comments box, but we always appreciate feedback from everyone regarding our lecture series. You can go to tiny.cc/afteridea is the link. And thanks again. We'll see everyone next month.
All right. Bye-bye.